Hi everyone, my name is Erin Munsell and I'm a clinical pharmacist specialist in the NICU at Mott Children's Hospital in Ann Arbor. I'm excited today to talk to you a little about the NICU and give a brief introduction. I have no conflicts of interest to disclose. At the end of this presentation, my goal would be for you to be able to define commonly utilized neonatal terminologies and abbreviations, including those related to pregnancy, birth weight, growth category, and age. To identify the purpose of the hepatitis B vaccination at birth, including differences in recommendations based on patient-specific factors and available product formulations. To articulate the rationale for vitamin K prophylaxis at birth and key education points to discuss with caregivers and providers. And finally, to summarize indications and rationale for ophthalmia neonatorum prophylaxis, including treatment and monitoring. And we're going to start things off with terminology. Pregnancy terminology's typical description will include gravidity and parity. Gravidity is the total number of pregnancies, which will include both current and past pregnancies, regardless of the outcome. Parity is the total number of pregnancies carried over the viability threshold, which is 20 weeks and 0 days. We use a 5-digit system to further break down pregnancies, with G standing for the total number of pregnancies. T will be pregnancies terminating after 36 weeks gestation or full term. P will be pregnancies terminating 20 to 36 weeks gestation or our preterm deliveries. A is utilized to label pregnancies terminating before 20 weeks gestation. These could be abortions or miscarriages. And L is living children. When no pregnancy loss has occurred, you oftentimes will see the pregnancy history reported just as gravida para without some of this further breakdown, but this gives you kind of the most in-depth picture. Now let's apply that pregnancy terminology to a patient example. Lola is a patient who's pregnant for the first time. We would label her as a G1. If she experienced a miscarriage at 12 weeks of gestation, this would be a pregnancy loss, which, looking at the chart, would be a 1 in the A column. Lola becomes pregnant again, which increases her total number of pregnancies to 2. So we increase her G column from 1 to 2, and the remainder stays the same. This second pregnancy is carried to term at 40 weeks and is a live birth. Gestation stays the same at 2. She now has had 1 term delivery, so we'll increase that T column to 1. And she now has 1 living child, so we'll add a 1 to the final column. The third time Lola is pregnant, she carries triplets to 26 weeks gestation. This increases her total number of pregnancies to 3. She still has 1 historical term delivery. She now has 1 preterm delivery. Of note, even though this was a multiple birth, it still counts as a single parity. So the P column will increase from 0 to 1. She still has the 1 historical miscarriage at 12 weeks with her first pregnancy, and with the delivery of the triplets, she now has 4 living children. We would now classify Lola as a G3, P1, 1, 1, and 4. Once a neonate is born, we have several different ways to classify their weights. Extremely low birth weight infants are going to be those less than 1,000 grams. Very low birth weight infants will be less than 1,500, and low birth weight is less than 2,500. IUGR, or intrauterine growth restriction, is an estimated fetal weight less than the 10th percentile. This is a decline in growth of the fetal pace, and there's a lot of factors that can contribute, including maternal hypertension or preeclampsia that impacts the uteroplacental vasculature. A baby who is born SGA, or small for gestational age, will be less than 2,500 grams or less than 10th percentile for gestational age. And this is the neonatal manifestation of a baby who has IUGR. So they had growth restriction in utero, and when they're born, they are small for their gestational age. These babies have an elevated risk of hypoglycemia, temperature instability, polycythemia, and elevated mortality rates. AGA is appropriate for gestational age, and these babies will fall in the 10 to 90th percentile, with our LGA babies being the last category. These are greater than 90th percentile, and oftentimes this is seen in infants of diabetic mothers. Now moving from weight descriptions to age descriptions, there are a few different ways that you will see age reported in a neonatal patient. Gestational age, labeled GA, will refer to the time elapsed between the first day of the last menstrual period to birth. I've also included below a picture of what this looks like if you're a little bit more visual. So if you can see, conception to birth will refer to gestational age. Postnatal age, or PNA, will be the time elapsed after birth. So from time of delivery onward will be your postnatal age. Postmenstrual age, or corrected gestational age, which are often used interchangeably in practice, refer to gestational age plus the postnatal age. So as you can see in the bottom, that is the whole timeline put together. Applying those descriptions to a neonatal patient, let's take a neonate born at 28 weeks and 3 days that is now on day 10 of life. What would their gestational age be? 28 weeks and 3 days. That's the time from their conception to birth. What would be their postnatal age? 10 days. And finally, what would be their corrected gestational age or postmenstrual age? So again, that is going to be combining gestational age plus postnatal age. And that will be 29 weeks and 6 days. I've mentioned on a few slides so far preterm versus term when describing a neonate. So let's break that down a little more. The first section I want to talk about is prematurity classification. Any baby born prior to 37 weeks gestational age will be classified as preterm. These are further subdivided based on degree of prematurity. Moderate to late preterms will be those born between 32 to less than 37 weeks gestation. Very preterm are those between 28 to less than 32 weeks gestation, while our youngest patients, born at less than 28 weeks gestational age, will be classified as extremely preterm. Similar to their premature counterparts discussed on the previous slide, our babies born at term and beyond have their own subset of classifications. So if you remember from the previous slide, everything less than 37 weeks is classified as preterm, and you can see that listed here on the left side of this timeline. Beginning at 37 weeks, 0 days, up until 38 weeks, 6 days, babies born in this period will be classified as early term. 39 weeks and 0 days, up to 40 weeks and 6 days, earn a labeling of full term, while 41 weeks and 0 days, up to 41 weeks and 6 days, is our last section of term deliveries that are labeled late term. Any babies born at 42 weeks gestation and beyond are classified as post-term. The final section of terminology that I'll go over today is the APGAR score. This was developed by Dr. Virginia Apgar in the 1950s and is used to assess a neonate's clinical status immediately after birth. Although it is assessing clinical status, it's important to note that it is not predictive of mortality or neurologic outcomes. The APGAR score evaluates 5 signs: appearance, pulse, grimace, activity, and respiration. If you look at the top left-hand side of the table, the first sign color, or appearance, can be scored from 0 to 2, as are all the other signs. A score of 0 is considered least responsive, while a 2 is considered a healthy response. A baby that was born blue or pale would earn a score of 0, while a baby who looks healthy and pink would earn a score of 2. These scores for all 5 signs are completed at 1, 5, and 10 minutes of life. The resulting score helps give an immediate clinical assessment to providers. A score of 7 to 10 would be considered normal, and the condition is reassuring. Scores of 4 to 6 are moderately abnormal, while a score less than 3 is indicative of a need for immediate attention. Let's now switch gears into discussing hepatitis B. For those afflicted with hepatitis B, it is a chronic infection that's associated with increased risk of cirrhosis and hepatocellular carcinoma or liver cancer. Due to its role in liver cancer, hepatitis B was targeted for worldwide eradication. The reason that this virus has such an impact on this singular organ is because the liver is the primary site of virus replication. A 2015 article in Hepatology estimated that global deaths from chronic hepatitis B are between 310 and 340,000 per year. So this is a significant number. It's also estimated that as many as 2.2 million in the US may have chronic hepatitis B. It's worth noting that the US adopted a strategy for universal infant vaccination in 1991, but this is a significant issue. So there's a multifaceted approach to target eradication. This includes routine testing of all pregnant women, universal vaccination of infants, routine vaccination of previously unvaccinated children and adolescents, and finally, vaccination of adults who are at high risk for the hepatitis B infection. The hepatitis B vaccine dose administered at birth has a primary role for post-exposure prophylaxis, aiming to prevent perinatal transmission of the virus. Neonates that require this prophylaxis should be captured with hepatitis B surface antigen testing, but in mothers that did not receive the prenatal screening, birth dose ensures a broader capture and coverage. It also provides a safeguard from household exposure in the first 2 months of life until babies are able to receive their 2-month immunizations. A full complement of the hepatitis B vaccine series is 3 doses. You'll note I have on the slide that there's a potential for 4 total doses in the series, and this generally occurs if you are administering as part of a combination vaccine. We do this very commonly in our pediatric patients to reduce the total number of pokes that they receive. And it is okay, specifically noted on the CDC website, that 4 doses are safe and permitted when giving as part of combination therapy. It is important to note when looking at a patient's history which immunizations have contained hepatitis B, as this can often be a rate-limiting step for administering the next dose. There is a minimum of a 4-week dosing interval between the first and second doses of hepatitis B, and an 8-week minimum dosing interval between the second and third doses. The hepatitis B vaccine is generally very well tolerated. As with any injection, there could be a local site reaction with some pain, erythema, and swelling. The anaphylaxis incidence is low at 1.1 per million doses. There was an identification by the Institute of Medicine in 2011 of a causal relationship between hepatitis B vaccine and anaphylaxis in yeast-sensitive patients. So that is something to keep in mind if that is an issue for your patient. 78% of the reports submitted to the Vaccine Adverse Event Reporting System between 2005 and 2015 that are involving hepatitis B were related to multiple vaccine administrations. So you may get concerns from caregivers looking up adverse event reporting of vaccines. So that is something as well to keep in mind to educate them on, that those were not single administrations in the majority of cases. In addition to the hepatitis B vaccine administered at birth, you may also see neonates receive the hepatitis B immune globulin. The reason we give this immune globulin is based on the mom's prenatal screening. If their hepatitis B surface antigen was positive, that means the mother is infectious, either with acute or chronic hepatitis B virus infection, and we give the immune globulin to provide passive antibodies and temporary protection for up to 6 months until the neonate is able to mount their own response or active immunity to their vaccination series. Let's break this down based on a mom's screening results. If the mother is hepatitis B surface antigen negative and the neonate is stable and greater than 2,000 grams, the recommendation is to administer the hepatitis B vaccine within 24 hours of birth. If the neonate is less than 2,000 grams to a hepatitis B surface antigen negative mother, the recommendation is to give the vaccine at 1 month or at hospital discharge, whichever is earlier. The reason we delay administration in the less than 2,000 gram population is due to a lower vaccination response in our low birth weight neonates. There's an increase in seroprotection when the low birth weight infants are vaccinated at 1 month of life versus within the first 72 hours of life. All neonates in this category with a hepatitis B surface antigen negative mom would not receive the immune globulin and would receive vaccine only. Moving into the neonate of a mother who tested hepatitis B surface antigen positive, they would receive the hepatitis B vaccine and the immune globulin, regardless of birth weight, within the first 12 hours of birth. These are administered in separate limbs, and we give, again, to all birth weight. There is no exception for the less than 2,000 gram category in this case, and we would administer a 4-dose total series to the low birth weight infants. So what if we don't have the prenatal testing, or we have an infant surrender situation, results aren't available? Those babies fall in the hepatitis B surface antigen unknown category. For these neonates, they should receive the hepatitis B vaccine regardless of birth weight. But what about immune globulin if we don't have that surface antigen result? For infants less than 2,000 grams, the recommendation is to administer hepatitis B immune globulin within the first 12 hours of life. This is due to the potential, as we've already discussed, for decreased immunogenicity of the vaccine in this population. So we want to give them that increase of protection with passive antibodies. If the neonate is greater than 2,000 grams with hepatitis B surface antigen results unknown, we will wait to administer the immune globulin until the results come back. If they are positive, we'll administer the immune globulin as soon as possible, but no later than day of life 7. A couple stats to keep in mind when looking at this combination in therapy. The hepatitis B vaccine efficacy alone comes in at approximately 75%. The immune globulin comes in at 71%. But when giving the two together, the combined efficacy is 94%. Now that we've spent time discussing the hepatitis B vaccine and the hepatitis B immune globulin in terms of neonatal therapy, let's touch on what options there are for maternal therapy for perinatal hepatitis B virus transmission prevention. We do have a couple antiviral therapy options. These are utilized in patients with a high hepatitis B virus DNA level and are initiated at 28 to 32 weeks gestation. Maternal therapy is typically discontinued at birth to 3 months postpartum. And again, this is an adjunct to the hepatitis B vaccine and immune globulin that will be given to the neonate after delivery. This antiviral therapy is only maternal therapy. Looking at agents that can be utilized, lamivudine and talbivudine use is very limited due to resistance, so the preferred maternal agent is tenofovir alafenamide. There are 2 different tenofovir formulations available, the alafenamide and the disoproxil fumarate. Both have shown safety and efficacy, but the alafenamide formulation is the newer agent that is preferred due to less renal and bone toxicity. It does have higher lipid levels and risk of weight gain, so that could be a factor when determining appropriate therapy for a mom. As we wrap up our discussion about the hepatitis B virus, I wanted to take a moment to look at the available vaccine formulations. The single antigen formulations, Recombavax and Energix, will be those utilized for the birth dose of hepatitis B, as they contain only the hepatitis B vaccine. A couple of the combination formulations that I had mentioned earlier, you might see Pediarix, Twinrix, there are others available on the market. The one that I use most commonly in practice is Pediarix. The reason I prefer this formulation is because of the number of combinations in it. So diphtheria, tetanus, pertussis, hepatitis B, and polio. You will see varying practices at many institutions, but remember to keep that in mind with the minimum dosing interval for subsequent doses. As a reminder, the hepatitis B is a 3-dose vaccine series, with 95% of infants having protective antibody response. One important counseling point that frequently comes up with families is to go over the lack of thimerosal in these immunizations. Thimerosal, if you're not familiar, is a mercury-based preservative that was utilized for many years in multi-dose vials. And it's important to let families know that none of these vaccines contain thimerosal. So how are we doing? We've talked about this goal for universal eradication. What kind of impact have we had? The rate of reported acute hepatitis B virus infections has declined 88.5% since recommendations for the hepatitis B vaccine were first issued. That has taken us from 9.6 cases per 100,000 in 1982 to 1.1 cases per 100,000 in 2015. That is a huge impact, but it's important that we remain vigilant as healthcare providers and ensure that those numbers do not trend back up. The second component of our standard eyes and thighs bundle at delivery is the vitamin K injection. Vitamin K administration at birth has been a standard of care since 1961, following a recommendation by the American Academy of Pediatrics. Vitamin K is utilized to prevent vitamin K deficiency bleeding, which has an overall incidence of 0.25 to 1.7%. Vitamin K is essential to our clotting cascade and is responsible for activating clotting factors 2, 7, 9, and 10. Our neonates will have undetectable vitamin K concentrations at delivery, as vitamin K does not cross the placenta. Our neonates also are not yet colonized with organisms such as Bacteroides fragilis, which produces vitamin K in their intestinal tract. Depending on what type of feeds a neonate receives, they may have more or less supplementation with vitamin K. There is a very limited amount of vitamin K in maternal breast milk, but a far more substantial amount in the fortified formulas that neonates can receive. In either case, infants generally attain adult levels of vitamin K by about 6 months of age. There are 3 different types of vitamin K deficiency bleeding that you'll see in practice, defined as early, classic, or late. Early vitamin K deficiency bleeding occurs in the first 24 hours of life, presents as an intracranial hemorrhage, and can be due to maternal medication use. Some medications of concern to keep in mind when reviewing a medication profile of a mom are warfarin, anticonvulsants such as phenytoin, and antituberculosis medications such as rifampin or isoniazid. Classic vitamin K deficiency bleeding occurs in the first week of life, and you may see nasal, cutaneous, gastrointestinal, and wound bleeding. This occurs in newborns that did not receive vitamin K prophylaxis. So as you recall, they don't have vitamin K from the placenta. They may not be producing in sufficient quantities yet from their GI microbes. And if they're not receiving fortified formula, they're getting a very limited amount from maternal breast milk. Late vitamin K deficiency bleeding occurs between 2 to 3 months of life, may present with intracranial, gastrointestinal, or cutaneous bleeding, and is exclusively seen in our breastfed infants. There are a few different types of vitamin K available. The first being vitamin K1. This is going to be present in your green leafy vegetables, typically something that we're counseling on for patients who are on warfarin. Think of your kale, your spinach, your collard greens. This is your K1. Vitamin K2 is produced by our GI flora. So the Bacteroides I mentioned a few slides ago, that is where your vitamin K2 is coming from. The kind we spend our most time with as pharmacists is vitamin K3. So the synthetic medicinal form of vitamin K. It's water soluble and we give it oral, IV, or IM. While there are multiple administration routes for vitamin K, let's take a minute to examine the counseling points of each. Intramuscular administration is a one-time dose with no reported treatment failures. However, the adverse effect concerns that have been raised are what typically give caregivers pause and where a lot of questions will come from. As you can imagine, the one on this list that draws the most concern is cancer. There was a study published in 1990 in the British Medical Journal by Goldberg that found an association between vitamin K administration and childhood cancer. An additional study noted doubling of childhood leukemia rates in patients receiving IM vitamin K, but found no association with oral administration. Based on this, the British Pediatric Association recommended routine use of oral prophylaxis in healthy newborns. To follow up, in 1999, the WHO's International Agency for Research on Cancer reviewed the available literature and concluded there was insufficient evidence to claim causation of cancer from intramuscular vitamin K. Additional research was also published in 2002 and 2003 that supported this statement from the WHO. So why are we still talking about this 20 years later if we have data showing that there's insufficient evidence for a cancer claim? We're in a very similar historical situation as with the vaccine linked to autism. And once the information is out there, it's very difficult to change public perception. A couple other adverse effects listed here: jaundice, injection site reaction. These really aren't things that caregivers typically bring up, as they are often most concerned with the cancer. Oral administration is a multi-dose regimen that does have reported treatment failures, and there's no established regimen. There has been an increase in late vitamin K deficiency bleeding with oral dosing, with a failure rate of 1.2 to 1.8 per 100,000 births. In those that don't receive complete oral prophylaxis, the rates increase to 2 to 4 per 100,000. There is a potential that small daily doses of oral vitamin K may provide similar efficacy to the IM dosing, but further studies are needed. Oftentimes, the rationale utilized for refusal of vitamin K is parents wanting a natural birth or just overall question of mainstream medicine. There is a vitamin K fact sheet available on the CDC website that can be utilized during education and discussion with caregivers to ease concerns and answer their questions. If your initial discussion amongst presentation of data from the WHO and 2002 and 2003 studies is not effective. Now let's move into dosing. We're going to start with intramuscular, and dosing is based on weight and gestational age. For those with a birth weight less than 1,500 grams or preterm neonates, dosing is recommended to be 0.3 to 0.5 mg per kilo times 1. For birth weights greater than or equal to 1,500 grams or a term neonate, recommended dosing is 1 milligram intramuscularly times 1. The dosing for neonates less than 1,500 will vary within the 0.3 to 0.5 mg per kilo range across institutions. Some utilize flat dosing ranges versus weight-based dosing for all very low birth weight infants, and this is just an institutional practice. So if some vitamin K is good, is more better? There were attempts made to utilize higher doses of vitamin K, and they studied doses greater than 5 milligrams per day. Unfortunately, they noticed an increase in hemolysis, severe jaundice, and kernicterus. This is why you see the dosing listed above and why we don't continue to escalate dosing as you might in some other situations with bleeding. Moving from intramuscular to oral, as I mentioned, there is no well-established regimen available. There are many to choose from. I've listed a couple options here that could be given to caregivers as a potential recommendation. You could do 2 milligrams of oral vitamin K at birth, followed by 2 milligrams at 3 to 5 days of life, and 2 milligrams at 4 to 6 weeks. 2 milligrams with the first feeding, followed by 2 milligrams in the first week, and then weekly administration while continuing to breastfeed. Or 2 milligrams after the first feeding, 2 milligrams within the first week, in daily administration of 25 micrograms for 13 weeks. This is a point that I try very clearly to educate residents, or if I have learners on rotation, we talk through which option, if requested by families, may be the most practical. And there's a couple things to take into consideration. The first option looks a little bit more appealing. You get one while you're in the hospital, one at 3 to 5 days of life, and one at 4 to 6 weeks. 3 doses and done. Seems very simple. The problem is, while most families will remember the first 2 doses, there is a fairly high likelihood that the 4 to 6 week dose could be missed if this is not handed off to the PCP. So that is something at hospital discharge that I always stress to residents to make sure is in their note and sign out to the primary care provider that this neonate will require a repeat dose of vitamin K, so someone is following up on it. The other options, weekly administration. From a medication adherence perspective, this is a little bit more attractive, as is the final option, but all of these are something that can be discussed with caregivers to determine what works best for them. And again, my primary focus as a NICU pharmacist, I just want to ensure that someone on the outpatient side is following up to make sure that continued administration occurs. The final piece of our eyes and thighs bundle at delivery is erythromycin eye ointment. Erythromycin is administered to prevent ophthalmia neonatorum, which is conjunctival erythema, swelling, and discharge that we see in the first 4 weeks of life. You may also heard this referred to as Creed's prophylaxis, and this is because in 1881, Dr. Carl Sigmund Franz Creed in Germany began washing newborn eyes with a 2% silver nitrate solution to protect against neonatal conjunctivitis caused by Neisseria gonorrhea. The overall incidence of ophthalmia neonatorum is between 1 and 12%. As I mentioned in 1881, they were primarily concerned with Neisseria gonorrhea being the causative organism. However, this now accounts for less than 1% of all cases, with chlamydia trachomatis causing 2 to 40% of cases, with other organisms such as staphylococcal, streptococcal, and Haemophilus species making up the remainder. Ophthalmia neonatorum now includes any conjunctivitis seen in this age group. The reason we are concerned about giving prophylaxis is the risk for corneal ulceration, scarring, and permanent visual impairment if left untreated. The standard of care is erythromycin, but there are a couple alternative agents available, such as silver nitrate and tetracycline. It is important to note that gentamicin ophthalmic ointment is not recommended and should be avoided due to severe ocular reactions. There is a strong recommendation in the kids list, so the key potentially inappropriate drugs in pediatrics, to avoid gentamicin ophthalmic ointment with a high quality of evidence. Administration of erythromycin ophthalmic ointment prophylaxis occurs immediately after birth, generally within the first hour, and is a one-time dose. You will see nurses give as a ribbon of ointment into the conjunctival sac. As is the administration of any type of antibiotic, there is potential for increased organism resistance. We have seen this with an increased resistance of gonococcal isolates. Erythromycin is also not efficacious against chlamydia, which can represent up to 40% of cases. Erythromycin ophthalmic prophylaxis is mandated by law in many areas, but there is potential for removal of eye prophylaxis, which we'll touch on in the next slide. It has been eliminated in Canada, however. So how do we move towards elimination of this eye prophylaxis in the United States? The American Academy of Pediatrics supports reevaluation of universal prophylaxis in the setting of the following criteria. Compliance with CDC prenatal screening, so this is screening for Neisseria gonorrhea and chlamydia trachomatis to prevent intrapartum exposure. Testing of unscreened women at labor and delivery with subsequent treatment of both mother and baby if treatment is indicated. Conjunctivitis counseling, which would be adequate counseling to parents on the potential severity and consequences of conjunctivitis and the need to inform providers if they have any concerns. Newborn providers must also be educated in the need for thorough evaluation and treatment of purulent conjunctivitis. Mandatory reporting will also allow for identification of failures in these primary prevention strategies. If gonorrhea is prevalent, or if prenatal screening or treatment is unavailable, the recommendation is to continue mandatory prophylaxis in those areas. I know we've covered quite a bit of info in terms of your introduction to the NICU, but let's brush up on a few of the key concepts we've covered. The abbreviations utilized in the neonatal population have the potential to cause significant confusion. It's important to verify appropriate acronyms are utilized to ensure clear communication. The hepatitis B vaccination is recommended for administration in newborns as a method to target worldwide eradication and prevent perinatal transmission of the hepatitis B virus. Intramuscular vitamin K prophylaxis is recommended for prevention of vitamin K deficiency bleeding due to efficacy and dose simplicity. And finally, despite a decline in maternal Neisseria gonorrhea infection rates, ophthalmic prophylaxis with erythromycin remains standard of care to prevent sight-threatening infections. Removal of this prophylaxis will require strict adherence to preventative measures. Let's now move into the assessment questions. Question number 1. EP is a 37-week, 2-day neonate on day of life 1. The parents initially refused intramuscular vitamin K following delivery, but are now requesting information on oral versus intramuscular administration. Which of the following education points do you feel will be most beneficial to include in your discussion? A. Intramuscular and oral vitamin K administration both require a one-time dose to ensure adequate vitamin K deficiency bleeding prevention. B. Neonates receiving breast milk as their sole form of nutrition do not require vitamin K prophylaxis due to the amount present in maternal milk. C. Oral vitamin K dosing is available as an alternative to intramuscular, but requires repeat dosing and can be associated with treatment failure. Or D. Oral vitamin K administration has increased in popularity due to negative effects of intramuscular administration, such as childhood leukemia. The correct answer for number 1 is letter C. Oral vitamin K is available as an alternative, but requires repeat dosing and can be associated with treatment failure. Question number 2. EK is a 29-year-old female admitted to your labor and delivery unit for the birth of her 24-week, 4-day child. The baby is now day of life 8 and weighs 568 grams. Which of the following is an accurate description of this neonate? A. Very low birth weight with gestational age of 24 weeks, 4 days. Low birth weight with postmenstrual age 25 weeks, 3 days. Appropriate for gestational age with gestational age of 25 weeks, 3 days. Extremely low birth weight with postmenstrual age 25 weeks, 5 days. Or small for gestational age with postmenstrual age 24 weeks, 4 days. And the correct answer here is going to be letter D. So with a birth weight of 568 grams, this neonate would classify as extremely low birth weight. And moving into the gestational age, postmenstrual age, second half of these answers, the gestational age is 24 weeks and 4 days, but the neonate is now 8 days of life. So to get postmenstrual age, you would add together the gestational age of 24 weeks, 4 days, with the postnatal age of 8 days, for a postmenstrual age of 25 weeks, 5 days. Question number 3. Which of the following is a potential preventative strategy for ophthalmia neonatorum? Please select all that apply. A. Education for healthcare providers on the need for swift and thorough evaluation of purulent conjunctivitis. B. Prenatal screening for Neisseria gonorrhea and chlamydia trachomatis to prevent intrapartum exposure. C. Mandatory reporting of gonococcal ophthalmia neonatorum in order to identify trends and potential failures of prevention strategies. Or D. Adequate counseling to caregivers on the potential severity of conjunctivitis and need to inform primary care provider. And the correct answer for question number 3 is all of the above. All of these are potential preventative strategies to reduce ophthalmia neonatorum. Question number 4. Which of the following patients is not eligible to receive a hepatitis B vaccination at birth? A. A 34-week, 6-day neonate weighing 2.4 kilograms. B. A 28-week, 2-day neonate weighing 1.4 kilograms, in which the maternal hepatitis B surface antigen is unknown. C. A 32-week, 1-day neonate weighing 1.8 kilograms, in which the maternal hepatitis B surface antigen is negative. Or D. A 41-week, 3-day neonate weighing 3.2 kilograms. The correct answer for number 4 is going to be C. The reason this neonate is not eligible is because their weight is less than 2 kilos. Because the maternal hepatitis B surface antigen is negative, this neonate would be due to receive their initial hepatitis B vaccination at 30 days of life or hospital discharge, whatever occurs first. The other answers are incorrect for the following reasons. Letter A, the neonate is greater than 2 kilos and hepatitis B surface antigen is negative. That neonate is able to receive within the first 24 hours of life. Letter B, while the neonate is less than 2 kilos, the unknown maternal hepatitis B surface antigen makes this baby eligible to receive despite their birth weight. And letter D, this neonate would be eligible to receive because they weigh 3.2 kilos and the maternal hepatitis B surface antigen is positive. So they would also be receiving the hepatitis B immune globulin. Our final question of this presentation, which of the following is a potential oral vitamin K prophylaxis regimen to discuss with caregivers who have refused intramuscular vitamin K? Letter A, vitamin K 2 milligrams by mouth following the first feed with 2 milligrams during the first week of life and 2 milligrams by mouth once weekly while breastfeeding. Vitamin K 4 milligrams by mouth following the first feed with 2 milligrams daily for the first month of life. Vitamin K 1 milligram by mouth immediately after birth. Or vitamin K 1 milligram by mouth daily for the mother for the duration of breastfeeding. And the correct answer for number 5 is going to be A. Again, oral vitamin K is going to be a multi-dose regimen, and it's important to remind caregivers that treatment failure is a potential. This is something we get asked a lot of questions on, which is why I wanted to bring it out as an assessment question. The IM dosing is very well established at most institutions, and we don't get that many questions on the pharmacy side. So something to be prepared for if you're practicing anywhere with a labor and delivery unit or with a NICU. You may get phone calls as a pharmacist on how to give oral vitamin K, and we often provide education to medical residents on how to counsel the family. Here is a list of my references. That brings us to the conclusion of this session. Thank you for taking the time to listen to this introduction to the NICU. I hope you enjoy the remaining competencies and find them beneficial.